all the, you take about 30 ml of bone. You can take 30 ml of bone. That is the beauty. And once you do that, then the brain becomes much more lax. It is not like when you have all the basal bone. It's just like any other skull base case. If you don't open without the skull base, if you open without the skull base work, then the brain's going to be very, very tense. But if you take off all the bone in the base, that's you get some time. So you can see the damage there. That's the posterior clinoid process. That's the carotid. You're going in. So that's the basilar, the EVD, unherniating. This is something that we do. The temporal lobe has gone inside. We raise the temporal lobe just very gently. If sometimes we have to excise it, but sometimes raising is okay. You can see the post-op scan here. And for the post-op scan, you will see this patient. This is him. You cannot imagine this happening for a decompressive hemicraniectomy. Ultramicroneurosurgery, we started in 2017. So with the Pentero microscope, which we put in a three-step magnification changer along with the ProMag eyepiece, so we could get a magnification of 42 technically. Zeiss company knows about this. This was probably the only one engineered to be like that. Apparently, the Zeiss people told us because it completely. I had a 3D head and it completely. I mean, put the entire system in imbalance, so we had to send it back. But when they gave me the Kinevo in 2020, they put that three-step magnification changer from the old microscope. But then in 2020, we shifted onto the exoscope, so which provides us magnification for over 40, sometimes up to 70. Now, this is an example. This is a Sylvian dissection. You can see the magnification, and you can see ultramicroneurosurgery in action here. You must remember is what we learned from Professor Yasargil and his students, just that we are carrying the torch and moving forward so that, as Mustafa said, the summit is much more higher. We are at different points, but we have to define points. We cannot stop where our people before us, the masters before us, stopped. They showed us the way, and it's our job to go ahead. So yes, so we define vessels which are very small and go ahead and define all corridors. You can see the zoom as 5.18, but this is on a 56-inch screen where we use it. It's 10 times more. That is almost 55 zoom. You can see how we even designed our own instruments because many of the instruments that we got were not ultra microneurosurgery ready. And this is exactly what the young I would want the young neurosurgeons to learn. Going between windows. Mustafa said there are some things, of course, that are inoperable or are maybe common sense doesn't allow you to operate, but then there are very few. And the so-called maximal safe resection is something that people hide their incompetence. Uh, Sometimes what is necessary for somebody who talks about maximal safe resection is to visit the lab, but it is it is not. People have different perspectives. I have had a lot of tumors where unknowingly I have left a lot of tumor in the beginning of my career and sometimes even now. So this is not the intent though, but if you go with that kind of an intent that I'm going to leave tumor, that's sad. So we all fail, but the intent should be right. That's the whole thing. If you have the right intent, then you're going to do well. So the whole thing is to, as Mustafa said, the whole thing is to go very patiently. And when people say it's impossible, when you hear the term impossible, you must think this is going to be fun. Okay, that's exactly how you need to go. And that's the attitude that will, take you. So you see, this vessel, even that vessel is important. So it's very easy to bipolar it and just take it aside. But at this zoom, when you see it, why not dissect it out? Okay, you can dissect it out. So I mean, you may say, oh, this is not needed, you know, but when you didn't have the microscope, this is precisely what people used to say, this is not required. So you see how you can open the whole door all the way, every two. We're not even thinking about aneurysm at this point. The only thing that I am thinking of is the next white band. That's all. Where is the next white band? Where can I open the next white band? I need to focus, see, and open each band. I think the youngsters need to learn that. Another surgery, this is a ACOM. I wouldn't go too much into it now. So again, ultra microneurosurgery zooms of 40 when we go near the aneurysm. Yeah, I don't like taking gyrus rectus for most of my cases unless it is really necessary. So what I do is I open the interhemispheric system. And with the exoscope, the angle is beautiful because with the microscope, opening the interhemispheric with the terional sometimes becomes a little bit of a, not a surgical issue. The assistant finds it very difficult. It will be a very difficult position you'll be standing into. With the exoscope, there's no such problem at all. You can see the interhemispheric being dissected beautifully. And once you dissect that, you get into the neck of the aneurysm. And once you have the neck of the aneurysm, you can go and you can click. This is under very, very high zoom. Go ahead, and then after you put the clip there, you can see the distal vessels there, and you can put the clip firm with an ICG. We've been lucky enough to be considered as one of the three classifications for the internal carotid extradurally. So this paper was published from a South American group, my good friends Matthias Baldoncini, and we've been talking about this classification schematic of IC segments. Maybe this is beyond, we will not talk in detail about this, but this is, you must remember all the segments that are vertical are odd numbered. So C3, C5, C7. All the others, horizontals are even numbered, C6, C4, and C2. And then it's so easy. And then you connect, and it is so easy. And the entire skull base builds around it. So this is our classification, very, very easy. So this has been our center in 2017. As I told you, we had the Pentiro at that time. We had an intraop 3 Tesla MRI suit at that time. We had the OR1 Neo from Carl Stoves and the Poinsettia. So we had a fantastic OR, one of the best ORs in 2017 anywhere in the world. And we were doing surgery. So that this is a place which is very distant and very remote in Nepal. And this is where we changed even further. This is intraoperative CT suite, which is in India. So it is a 192 slice CT, which we designed with Siemens to put it as an intraop CT. And then we started Sahasra Netra concept here. That's the Esculapios. We take the output from the CT, reconstruct it into VR, and inject into the exoscope field. This is something that we do with the DRDO and with a few agencies. The company that we do it with is Sanma, as I disclosed earlier. So we inject this into the as a mixed reality field, and this is what see you can see the robot moving there, and that is in this is in my field. Even without operating, I can see the head, and I can simulate the head, all the vessels, everything. I can move it around. And this is the first exoscope life surgery conference. Must have been in 2019 or something. This was in Russia. We were on the national news for that. We did a giant MC aneurysm. This is because the exoscope from the German companies were $1 million. So we went ahead and made the first generation exoscope in India with a company from India. It's called the Sanma Yoko. My daughter's godmother is Professor Kato, so hence the name Yoko. And this is a robotic holder, endoscopic robotic holder, named after my second daughter. It's a Santana. Both of them are now robotic, second generation, and this one, the third generation. Third generation combines this both actually. So you can hold the robot as well as the exoscope is also there. So um, this is this is what we do for innovations, and this is the bypass set. Every single instruments, we have gone to zooms of up to 70, 80 and examined these. They're made of stainless steel, and the whole set is half the price of a German set. That's how I wanted it to be placed. So we are a lot of people from South America, Africa, Asia. They are getting this set because it's literally dirt cheap. This is hypervision, part of Sahasra Netra concept. Putting the VR. This is something that we put it on a textbook in 2017. It is a VR integration into the real field. This is something that we did with the Special Forces soldier. He was the mental fitness coach for one of our premier cricket teams. And then what we did is we using feedback like heart rate variability, pulse rate, um, and other parameters. We made a program so that we know that when somebody is being pushed, somebody is under stress. Even before they start to manifest, when somebody is under stress, we can tell them, see, listen, you're under stress, and there is a way to get over it. So why we termed it beyond flow is because if you see musical instruments being played, they play in flow. They do complex, very complex movements, and that is in flow. But for master surgeons, flow is not enough. You can perform in flow, but then when the aneurysm ruptures or something very uh, unexpected happens, then it can throw you out of flow. So that is why we decided that we should say beyond flow. It's a completely scientific program where it is like the elite Olympic athletes being trained. And my friend is he's been training Olympic athletes in India, and he's also trained number one badminton player from India. This is robotic surgery, and we are getting into this. These are the special instruments that we use. Another project that we are into now is, again, Mustafa talked about this, is about salvaging the penumbra for incomplete strokes. Recurrent TAs can also be added to the spectrum. We've been doing it for 7 years. CT perfusion studies to document the penumbra. The beauty is that we have a 3-month window period. So if you improve the perfusion in the penumbra, plasticity is much better because penumbra is not, it's viable, but it's not functional. So if you reperfuse the penumbra, functionality starts there. This is our hypothesis, and we've had This is the bypass that we do again, ultra microneurosurgery. It's zero point 0.7, zero point 0.7 millimeter vessels, five sutures here, five sutures there, two on each. So 12 to sometimes 14 sutures. We use 11 zeros. And you can see 31 patients from 2017 to 2025 is still continuing the study, incomplete MCA strokes. DSA and MRI ensure to assess the vascularity with algorithms that show the perfusions with the AI being developed. Significant difference in GOS at 6 months and improvement in perfusion. I see that Utah, my good friend Bill Coldwell is also doing this now. I think Barrow has also started. China, Zubin tells me that it is a part of the Chinese stroke protocols. Now, this is the surgery again, the anastomosis. You can see uh, so M4, ST to M4, very, very high zoom. Wet dry field. You can see so that's the bypass. So doing the farther side first, and sometimes I do it both ways. I mean, there is no strict way for me to do it, whatever I'm comfortable with. You can see the bypass now, done. And you can see this vessel irrigating when you do the ICG. You can see the direction of blood flow also is beautiful. You can see the direction of the blood flow, and then it's being irrigated beautifully. So another thing that we developed over the years now we started talking about is the vestibular schwannomas. I see a lot of surgeons trying to do subtotal or partial resections, but anybody who does the complete resection takes it off with the capsule, and then you have problems saving the cochlear nerve. So we looked at it, and then we found out that there is a subperineural around it, and if you go at the subperineural plane, the vascularity is between the perineurium and the eighth nerve. Seventh nerve saving is not a big issue, but eighth nerve, when the tumor is large, if you disturb the perineurium, if you take it off, peel it off with the perineurium, then you're never going to get your eighth nerve function back, or improvements will be unheard of. So you need to go subperineural. This is not incomplete resection. Please understand that. You say you A lot of people say you're keeping the capsule there. There's not really a capsule. It's so thin. It's really so thin that you can see the seventh and eighth nerves through the capsule. People who have assisted me would have seen this, and this is the concept. So you go into the capsule. Usually you used to go in this plane. Now you go into this plane, take out the tumor completely, use an endoscope. If towards the brainstem side or towards the IAM side, you can take out the entire tumor. This is how it will look. So at the end of the day, you have this blood supply, that is a vasa nervorum, is not disturbed. The cranial nerves are not disturbed, and you can take it out. We've never had for the last 7 years, we've been doing it. We have seen some cysts, but never needed resurgery. We've been watching them. This is some work we do in South America, in Central Asia. We have fellows, as Mustafa said, passing on our knowledge is very, very important too. So, Africa, and this is something that really excites me. It's a portable MRI which can be worked like a Lego unit. So it's something that really excites me. I'm with them. It's an Indian company doing it with the US company, and it's truly exciting. So it would be, I think, the future. It will change the way neurosurgery is done. I just wanted to show you one video. My life has been around this, that everything is simple, and I've tried to convince others, but when you are conditioned to think that nothing is simple, then you make things hard for you. I believe everything is simple. If you pay attention to the details, to the right details, then everything is simple. Thank you very much. God bless. Thank you, Sami. Thank you, all my fellow speakers. Honored to be on this podium.